around 20% of stable patients with no prior heart failure hospitalization during this period of this Paradigm HF trial were found to have a primary event. So there is no such thing as stable heart failure. The condition is a progressive disease. 17% of the patients died during the trial. And of the stable patients who experienced the primary event, the patients died even before heart failure hospitalization. In about 50% of those patients who died even before they were hospitalized. So the death may occur suddenly, it may occur due to heart failure hospitalization. Now, ARNI has been shown to impact both the mechanisms of mortality in heart failure patients. It reduces the incidence of pump failure deaths, and it also reduces the incidence of sudden cardiac deaths. So we are having a dual or comprehensive benefit of ARNI as compared to ACE inhibitors in terms of mortality benefit. And this is why all the major guidelines now tell us that encourage us to switch from ACE inhibitors and ARBs to ARNI even in stable patients to prevent these two outcomes, and to use ACE inhibitors only in patients who are intolerant to ARNI, and only when patients are unable to be prescribed ARNI should we think of the other two classes of RAS inhibition. The number 2 point is that from the Paradigm HF, we learned that in stable patients giving ARNI was useful, but we also understand that patients who are just being discharged with an episode of acute heart failure, they are at high risk of having readmissions for heart failure within a short period of time, including within 1 month. So the Pioneer HF trial was mounted to understand whether ARNI can be exhibited to patients who are recovering from ADHF and does it have any meaningful benefits. So the Pioneer HF trial enrolled patients while still in hospital who were relatively stable to sacubitril valsartan combination of 100 mg twice a day and compared it to enalapril 10 mg twice a day. And when they ran it for a period of 8 weeks, they found that the dose was well tolerated by the patients. There was a significant decrease in the NT-proBNP biomarker for heart failure, and there was also a significant trend towards reduction in CV death or hospitalization even within 8 weeks of randomization, and the curve started diverging very early within 2 weeks of initiation. So it is important that we start this molecule as early as possible after an episode of acute heart failure to prevent further episodes of heart hospitalization or mortality for these patients.